Welcome to the Deep Dive. This is where we take the most dense, complex clinical knowledge, distill it, and deliver the essential insights you need to excel. Today, we are undertaking a really critical deep dive into the chapter covering the management of patients with oral and esophageal disorders.
Yeah, this stuff it's truly foundational material. When we look at the upper GI tracts, from the lips and teeth all the way to the pharynx and esophagus, we're talking about the gateway to nutrition.
And communication.
Right, the mechanism for communication, and really a central pillar of overall systemic health. Disruptions here, whether they're inflammatory, infectious, or cancerous, they immediately jeopardize a patient's entire well-being. Our mission today is to give you a structured step-by-step path through all this, focusing on the clinical priorities that save lives.
Okay, so before we jump into the specific disorders, let's quickly lock down some vocabulary. These are the key concepts that are going to define the pathology we'll be discussing.
Right. First, we need to be crystal clear on achalasia. This is a motility disorder where the distal esophagus, it just loses its ability to perform effective peristalsis. So the muscles just don't push the food down.
And the sphincter is involved too, right?
Crucially, the lower esophageal sphincter fails to relax when you swallow. So it's a functional blockage, a real physiological bottleneck.
And when patients complain about problems with eating, we need to distinguish between dysphagia and odynophagia.
That distinction is paramount for nursing assessment. Absolutely. Dysphagia is simply difficulty swallowing. It doesn't matter if it hurts or not. Odynophagia, on the other hand, is pain when swallowing. That usually signals inflammation, ulceration, or infection, and it's a real red flag.
Okay, next up, a term we hear all the time, pyrosis.
Yeah, that's just the burning sensation, the classic heartburn that originates in the stomach or esophagus and often, radiates up into the throat. It's the hallmark symptom of reflux.
Then there is that infamous post-surgical issue, dumping syndrome.
Yes, sometimes they call it vagotomy syndrome. This is the rapid emptying of hyperosmolar gastric contents directly into the small intestine. And this swift transit triggers this massive physiological response: nausea, weakness, profuse sweating, cramping.
And that osmotic diarrhea.
And osmotic diarrhea. It's just a debilitating cycle of symptoms that we absolutely have to prevent after certain surgeries.
And finally, an intervention term, enteral nutrition.
This one's simple. It just means delivering nutritional formula through a tube directly into the GI tract. It completely bypasses the need for oral consumption, and this is key, it relies entirely on a functional digestive system downstream.
Okay, with our vocabulary set, let's start right at the beginning.
Okay.
We're moving into the disorders of the oral cavity. And you really can't talk about overall health without recognizing the significance of the mouth.
Absolutely not. The status of a patient's oral health dictates their ability to maintain adequate nutrition. If there's pain, missing teeth, inflammation, they're just not going to eat. And the single biggest culprit for adult tooth loss is periodontal disease.
The prevalence of periodontal disease is, shocking when you look at the numbers. What do we need to internalize here?
The data shows that roughly 45.9% of adults aged 30 and older in the United States have periodontitis.
That's nearly half the adult population.
Nearly half. And when we talk about modifiable risks, smoking is the giant elephant in the room. Cigarette smokers increase their risk of developing this disease by at least 50%.
And that immediately takes us from thinking of this as just a dental problem to seeing it as a systemic health crisis.
Yeah.
What are the documented links between periodontal disease and major chronic illnesses?
This is where routine care becomes systemic care. The links are really well established. We see connections between periodontitis and cardiovascular disease, diabetes, and rheumatoid disease. The pathophysiology is that the gram-negative bacteria that are so prevalent in periodontitis trigger this widespread inflammatory response throughout the entire body.
So we're talking about an increase in inflammatory markers then.
Exactly. You see elevated C-reactive protein, increased white blood cell counts, and higher fibrinogen levels. These are all directly correlated with increased cardiovascular risk, including, the promotion of atherosclerosis. There's even some preliminary data suggesting that oral bacteria, like Streptococcus mitis, have been found in the cerebral thrombi of stroke patients.
Wow.
Yeah, it raises this kind of provocative idea that poor oral hygiene could be directly contributing to thrombotic events elsewhere in the body.
That makes the nursing oral assessment even more critical. When we're looking at the mouth, we need a rapid-fire clinical reference to identify problems. Let's kind of mentally walk through the common abnormalities that nurses should be screening for.
Okay, let's start with the lips. We often see actinic cheilitis. This is a chronic inflammation from sun exposure, and crucially, it is considered pre-malignant squamous cell cancer.
So the nursing implication is immediate.
Immediate education on sun protection, especially for fair-skinned patients. We also see contagious lesions like chancre, that's primary syphilis, and herpes simplex virus 1, or cold sores. Both require patient teaching on transmission and management with antivirals.
Moving inside the mouth. What about the common aphthostomatitis, the standard canker sore?
These are painful, often linked to minor trauma or some kind of immune response. They have a distinct white-yellow center with a bright red border. Management really just focuses on comfort saline rinses, maybe some topical benzocaine, and sometimes corticosteroids if it's really severe.
And for the vulnerable patient, the immunosuppressed or those on antibiotics, we see candidiasis or thrush.
Right, that classic presentation of a cheesy white plaque. The key nursing instruction here is all about how you administer the antifungal suspensions, like nystatin. You have to instruct the patient to swish it vigorously for a minimum of 1 minute, making sure it coats the entire oral mucosa and pharynx, and then swallow the medication.
Just swabbing the mouth isn't enough.
It's totally insufficient.
Okay, now for the serious warning signs. Leukoplakia and erythroplakia. What's the difference in the malignancy risk here?
Okay, so leukoplakia is that painless, white, often slightly rough patch. It's overwhelmingly associated with tobacco use. Thankfully, less than 2% of these lesions actually become malignant. Erythroplakia is the red, velvety lesion. This is the one that sets off all the alarms.
That's the one to worry about.
It carries a significantly high risk of malignant transformation. If a nurse sees this, the priority is immediate cessation of tobacco and alcohol and a prompt referral for biopsy.
And finally, stomatitis, that generalized oral inflammation, which often complicates cancer treatment.
Right. And this highlights the need for prophylactic mouth care. When patients are getting chemo or radiation, especially to the head and neck, they are highly susceptible to secondary infections and severe pain from mucosal breakdown, which we call mucositis. Aggressive, meticulous oral hygiene is preventative medicine here.
Let's talk about dental caries and prevention. We know the basic pathophysiology, bacteria, and carbs-making acid. But what are the effective prevention strategies we should be teaching?
The 3 pillars are really clear: fluoride, sealants, and community water fluoridation. Fluoride varnish or gel is standard. Dental sealants provide a physical barrier on the chewing surfaces. They're highly effective and can last, 36 to 48 months. And globally, community water fluoridation is still one of the most effective public health measures out there, reducing decay rates by about 25%.
Shifting to patient care, the sources emphasize a critical nursing practice point for ill or dependent patients: the method of oral care. I know a lot of facilities use those foam swabs, but that's often not effective, is it?
It's often ineffective for plaque disruption. The gold standard for mechanical cleansing is, and remains, brushing with a soft, bristled toothbrush. You have to physically disrupt the bacterial colonies. If brushing is completely impossible, maybe due to pain or bleeding risk, the alternative is a gauze pad dipped in an antiseptic mouthwash. You use it to physically wipe and massage the gums and teeth, then rinse and expectorate if possible. Just wiping with a foam swab provides some comfort, but it doesn't adequately clean.
Okay, let's look at a particularly vulnerable population: older adults. What unique challenges do they face with oral health?
Oh, we see a devastating cascade here, and it's often driven by polypharmacy. Older adults are frequently on multiple medications: antidepressants, antihypertensives, diuretics, and a very common side effect is xerostomia, or dry mouth.
And what does that dry mouth trigger?
It creates a perfect environment for infection, it exacerbates gingivitis, and it severely impairs their ability to swallow and communicate. So you have poor dentition combined with xerostomia, which leads to decreased food intake, increased systemic infection risk from periodontitis, and sometimes really profound social isolation because they just struggle to speak or eat comfortably in public. A nursing assessment of their medication list is key to understanding their oral risk profile.
The last oral disorder on the list is the periapical abscess, the classic life-altering toothache. What is the clinical presentation and the management priority?
This is a localized collection of pus at the root of the tooth, usually from untreated caries. The patient will describe a continuous, dull, gnawing pain. You'll often see systemic signs like fever and malaise, and localized signs like swelling cellulitis in the face, sensitivity to temperature, and maybe trismus, which is difficulty opening the mouth.
And the management is all about immediate relief.
Yes. The number one priority is relieving the pressure. Usually that's done via needle aspiration or an incision through the gum line for drainage. Once the acute inflammation is down, the ultimate solution is either a root canal or tooth extraction. Nursing care really focuses on monitoring closely for any post-procedure bleeding, managing the pain, and instructing the patient on warm saline rinses and how to slowly advance their diet from liquid to soft.
That covers the front end of the system. Let's move slightly posterior now into Section 3. Disorders of the jaw and salivary glands. We'll start with temporomandibular disorders, or TMD.
This is a surprisingly broad category. The National Institute of Dental and Craniofacial Research classifies TMD into three main types. There's the common myofascial pain, which is pain in the muscles of the jaw, neck, and shoulder. Then there's internal derangement, which is a structural issue, like a dislocated joint. And finally, degenerative joint disease, which is basically arthritis in the jaw joint.
What are the symptoms that make TMD so frustrating for patients?
It's the sheer variety and persistence of the pain. It can be a throbbing ache that radiates down a neck and into the ear. They'll have restricted jaw motion, locking, and that audible clicking or popping sound when they move their jaw. It often comes with associated headaches, dizziness, and even hearing problems, which really complicates the diagnostic picture.
What's encouraging here, though, is the management strategy.
It is. The vast majority of cases improve over time with conservative, non-invasive therapy. We start with self-care. Soft foods, applying ice, cognitive behavior modification to address stress and clenching, and avoiding extreme movements like wide yawning. Physical therapy, acupuncture, and a brief trial of NSAIDs or muscle relaxants are usually the first-line treatments.
Now let's pivot to surgical jaw management, which is often for structural reasons, trauma, or cancer. We need to clearly differentiate between the two fixation methods, MMF and ORIF.
Okay, so maxillomandibular fixation, or MMF, is the traditional method, wiring the jaw shut. This means the patient has to be on a strict liquid diet for 7 to 10 days. It works, but it significantly restricts the airway in an emergency. The preferred modern surgical standard is open reduction, internal fixation, or ORF.
Which involves permanent plates and screws, so why is ORIF preferred?
ORIF allows for better long-term functional alignment and reduces the risk of long-term joint stiffness. And crucially, it allows for an earlier return to a modified diet. While the patient still needs a liquid or soft diet for longer, about 4 to 6 weeks, they have a patent airway and a better ability to maintain oral hygiene, which improves compliance and recovery.
So what are the absolute nursing priorities after jaw surgery?
First, managing that liquid or soft diet to make sure the patient gets enough calories and protein for bone healing. Second, meticulous oral hygiene to prevent wound infection, which can lead to osteomyelitis. And third, patient education has to aggressively target risk reduction. We have to enforce the absolute cessation of smoking or any electronic nicotine delivery systems because nicotine causes vasoconstriction, which dramatically increases the risk of non-union, hardware failure, and infection.
Okay, moving to the salivary glands. The first common inflammation is parotitis.
Right, inflammation of the parotid gland. It can be viral, like mumps, or bacterial. The bacterial form is critically important to spot because it often strikes older, debilitated, or severely dehydrated patients. It's often caused by Staphylococcus aureus ascending the parotid duct.
What does it look like clinically?
A sudden onset of high fever and chills, visible swelling and tenderness of the gland, and pain that radiates up into the ear, making swallowing extremely difficult. Management requires aggressive hydration, cold packs, good oral care, and immediate broad-spectrum antibiotics if it's bacterial. If it progresses to an abscess, surgical drainage, or periodontal is necessary.
And if the inflammation is generalized, we call it sialadenitis.
Right, and that inflammation is often caused by dehydration, radiation exposure, or the presence of stones or calculi. The management strategy here is pretty simple. Stimulate flow and reduce inflammation. So we use massage, warm compresses, and sialagogues, things like hard candy or lemon juice, to increase saliva production. For chronic duct issues, soundoscopy is an advanced technique that lets us visualize, dilate, and flush the duct.
Salivary often ties into managing the stones themselves, salilithiasis.
Salivary calculus. It's important to remember that about 80% of these occur in the submandibular gland. Obstruction causes this sudden acute colicky pain and swelling, which is classically relieved by a sudden gush of saliva when the stone moves.
And the treatment for these stones?
We can use silendoscopy to retrieve them, or for smaller stones, lithotripsy using shock waves to disintegrate the stone. It's non-invasive and often doesn't even require general anesthesia.
Finally, salivary gland neoplasms.
Most benign tumors will just present as a painless, slow-growing swelling. The clinical red flag that just screams malignancy is the onset of neurologic symptoms, like persistent pain or weakness and numbness involving the facial nerve, which is cranial nerve 7.
And the surgery here, especially for the parotid gland, must be incredibly complex because of that facial nerve.
It is the defining feature of the surgery. The surgeon has to carefully dissect and preserve the 7th cranial nerve to maintain facial function. A strange but well-documented complication after a periodonectomy is Frey syndrome. This is when the patient gets excessive facial sweating and flushing near the surgical site, but specifically while they're eating. Fortunately, it can be successfully managed using targeted botulinum toxin injections.
That's a powerful illustration of how a localized nerve injury can affect daily life. Let's move into section 4, cancer of the oral cavity and pharynx.
We have to start with the etiology. While we know alcohol and tobacco have this profound synergistic carcinogenic effect, the major epidemiological driver today is human papillomavirus, or HPV.
HPV is now linked to the majority of oropharyngeal cancers.
Up to 70%. These are typically squamous cell carcinomas found most commonly on the lateral tongue and the floor of the mouth. This linkage provides a tremendous opportunity for prevention. Studies are now showing that the HPV vaccine is highly effective, leading to an 88% lower prevalence of oral HPV infections in vaccinated young adults. It really underscores the importance of universal vaccination.
What are the key clinical manifestations we need to be watching for in these patients?
The problem is that early cancers are often asymptomatic. When symptoms do appear, the nurse is looking for a painless sore or lesion that bleeds easily and just fails to heal within the typical time frame. We're also watching for leukoplakia, the white patch, and critically erythroplakia, the red velvety patch, which, as we noted, has a much higher malignant potential.
And when the cancer is more advanced, what do patients report?
The later signs are all functional deficits. Persistent, worsening difficulty chewing, speaking, or swallowing. That's dysphagia, limited jaw movement, or trismus, and often unexplained weight loss.
Diagnosis involves careful examination, imaging like PT-CT or MRI, and fundamentally a biopsy. Let's focus on the management side, specifically the surgical management of metastatic disease via neck dissection.
This is a major area of complexity in postoperative nursing care. Because oral cancer so frequently spreads to the cervical lymph nodes, a neck dissection is often required, and the type of dissection dictates the postoperative functional deficit.
Okay, let's start with the most aggressive, radical neck dissection.
This procedure removes the lymph nodes, but it also removes the sternocleidomastoid muscle, the internal jugular vein, and the spinal accessory nerve. The functional and cosmetic fallout from this is severe. You get shoulder drop, chronic pain, and an altered appearance. It's really reserved for when the tumor burden absolutely necessitates it.
Then there's the more modern approach, the modified radical.
The modified radical neck dissection tries to preserve one or more of those non-lymphatic structures, the muscle, the vein, or the nerve, which leads to much better function and cosmesis.
And the selective neck dissection.
This is becoming the most common approach, particularly for HPV-driven oral cancers. It preserves entire lymph node groups, targeting only the highest risk areas for metastasis, thereby minimizing trauma and functional loss.
Regardless of the extent, reconstruction is often vital following the resection.
Yes. For large tissue deficits, the surgeon uses pedicled tissue flaps, that's tissue mobilized with its original blood supply intact, or increasingly, microvascular free flaps, which are harvested from sites like the fibula, the radial forearm, or the pectoralis major. The nurse has to recognize that any large resection, especially a total glossectomy or tongue removal, results in severe, permanent functional deficits related to speech and a very high risk for aspiration.
That brings us right to section 5, nursing management of oral disorders. Our focus shifts entirely here to maximizing recovery and quality of life.
And the first priority is aggressive mouth care, especially preventing oral mucositis, or OM, which is that painful inflammation caused by cancer therapy. If we don't manage OM, patients stop eating, and that derails their entire treatment plan.
What specific interventions are supported by current evidence for OM prevention?
The strongest evidence supports using multi-agent combination oral care protocols. The core intervention remains the simple, cost-effective rinse, a solution of about 1/4 to 1 teaspoon of baking soda or salt in 8 ounces of warm water. This increases oral clearance and promotes comfort.
Are there any interventions we should avoid or that are often misused?
For patients undergoing head and neck radiation, chlorhexidine is generally not recommended for OM prevention. And while magic mouthwash, that cocktail of lidocaine, an antacid, and an antihistamine, is widely used for pain relief, its overall efficacy in speeding healing is still debated, and it can be financially burdensome without a clear benefit.
But there is a high-tech solution that's gaining traction.
Yes, intraoral photobiomodulation, or PBM. This is a low-level laser therapy that's applied to the oral mucosa. It's showing very positive outcomes specifically for preventing or reducing the severity of mucositis in patients receiving radiotherapy.
Next, tackling xerostomia or chronic dry mouth, a major issue caused by radiation and common medications.
Management here focuses on replacing moisture and stimulating saliva production. Recommendations include constant sipping of water, using commercial oral mucosal lubricants or saliva substitutes, and applying oral moisturizing jelly or OMJ. For severe cases, pharmacologic agents that stimulate saliva can be used. Every intervention is geared toward improving the patient's ability to swallow, speak, and eat, which is all about maintaining their nutritional status.
How do we ensure adequate nutrition in a patient who's struggling with pain, dysphagia, or taste changes?
We have to move beyond just asking, "Are you eating enough?" We need a calculated approach. You start a daily calorie count, tracking intake from all sources, oral, supplemental drinks, or tubes. We have to rigorously assess the symptoms that inhibit eating pain, nausea, early satiety, altered taste. And critically, you must involve a registered dietitian early to calculate their energy needs and ensure the patient maintains a positive nitrogen balance to support healing.
Surgical intervention, particularly the neck dissection, often results in visible changes. How do nurses provide that psychosocial support and address body image changes?
This requires sensitivity and intention. The nurse has to create a safe space for the patient to verbalize their fears, their anxieties, and the perceived or actual changes in their appearance. This could be visible incisions, swelling, or the functional loss of a shoulder. We have to listen attentively and validate their feelings. Referrals to ACS programs like Look Good, Feel Better, and immediate consultation with psychosocial professionals are standard practice to support coping.
For pain management, beyond systemic analgesics, are there specific dietary considerations to minimize irritation?
Absolutely. The rule is soft, smooth, and moderate temperature. Patients must strictly avoid spicy, highly acidic, hard or crunchy foods like chips or nuts, which can traumatize the tender oral mucosa. Viscous lidocaine can be highly effective when applied topically about 15 to 30 minutes before meals, but we have to pair it with systemic analgesics, making sure we give them in a timely way to avoid anticipatory pain.
Infection prevention is huge, especially when patients are myelosuppressed from treatment.
This requires hypervigilance. The nursing standard involves checking lab results for leukopenia and monitoring the patient's temperature every 4 to 8 hours. If a patient is severely immunosuppressed, we must enforce a strict visitor prohibition to prevent transmission of pathogens. For the surgical site, we monitor for wound infection redness, tenderness, drainage, and for the desquamation reaction that occurs with radiation. We have to distinguish between dry desquamation, which is managed with topical lotions, and wet desquamation, which is open, weeping skin that requires specialized dressings.
For patients moving into recovery, what are the core teaching points for home and transitional care?
The teaching has to ensure competency for complex self-care. This includes proper technique for oral hygiene, how to prepare high-calorie, nutritious, seasoned foods. Commercial baby foods are often a practical option, and, if necessary, demonstrating mastery in administering and caring for complex devices. That could be enteral feeding tubes, tracheostomy equipment, or suction apparatus. The caregivers have to be fully involved in this teaching process.
Now we take this discussion on radical cancer treatment and transition into Section 6. The rigorous nursing process required for a patient undergoing a neck dissection.
This is intensive care. Preoperatively, the nurse focuses on assessing the patient's psychological readiness for what can be a disfiguring surgery and ensuring they understand the potential functional changes. We have to establish their baseline coping mechanisms and involve a speech pathologist to plan communication strategies ahead of time.
Post-surgery, the sheer volume of potential issues drives the nursing diagnosis list.
It does. It includes acute concerns like impaired airway clearance and acute pain, structural issues like impaired tissue integrity related to the graft viability and the surgical incision, and functional deficits like impaired nutritional status and impaired verbal communication or mobility. And of course, psychological risks like situational low self-esteem.
And the potential collaborative problems, the complications, are life-threatening.
Right. We are constantly monitoring for hemorrhage, which includes hematoma formation or, in the worst case scenario, carotid artery rupture. We watch for a leak, which is lymphatic drainage, and specific neurologic complications, primarily injury to the spinal accessory, vagus, and hypoglossal nerves.
Let's start with the absolute priority, maintaining airway clearance.
This is non-negotiable. The patient is placed immediately in the Fowler position, so with a high head of bed. This position does three things. It facilitates venous and lymphatic drainage, it decreases pressure on the surgical flaps, and critically, it aids swallowing to prevent aspiration.
And what is the definitive safety alert for airway obstruction?
If you hear stridor, that coarse, high-pitched sound on inspiration, you must report it immediately. Stridor signals a rapidly progressive airway obstruction, likely from edema, bleeding, or hematoma. Interventions include ensuring the patient performs coughing and deep breathing exercises while supporting the neck incision and utilizing Yankauer or tracheostomy suction as needed.
Wound care involves managing drainage and meticulously assessing graft viability.
Yes, we manage drainage tubes, typically Jackson-Pratt drains, which should remove about 80 to 120 milliliters of serosanguineous fluid in the first 24 hours. To assess graft viability, the nurse has to look for a pale pink color and warmth. A white or ashen color indicates an arterial occlusion, which is an emergency. Blue mottling or excessive purple suggests venous congestion. If there's any concern, a Doppler ultrasound must be used to confirm perfusion and the presence of a pulse at the graft site. And we have to caution against applying excessive pressure to that surgical site.
Adequate nutrition often relies on prophylactic intervention here.
Yes. Prophylactic tube feeding an NG tube or a gastrostomy is often placed during surgery. This is essential to prevent rapid postoperative weight loss and ensures the patient has adequate nutritional reserves to tolerate subsequent oncologic treatments like chemoradiation. And even if a patient is cleared for oral intake, meticulous oral care before eating is essential to enhance their appetite and taste sensation.
The psychological burden of this surgery is immense.
It really is. We have to address the patient's feelings about the visible changes. The bulky dressings, the altered facial appearance, the neck contour. Research shows us that patients who are communication vulnerable, those who are intubated or post-head and neck surgery, often suffer silently from depressive symptoms. The nurse's intentional, compassionate presence and validation are critical elements of care that go far beyond the technical. We also must strongly counsel abstinence from alcohol and tobacco, as it compromises prognosis and healing.
Promoting effective communication is also part of that psychosocial support.
Definitely. Preoperatively, you have to plan alternative communication methods, write-in tablets, communication boards, or electronic devices. Post-surgery, the speech-language pathologist is vital, introducing strategies like esophageal speech or the use of a voice prosthesis for those with extensive laryngeal involvement.
What about physical mobility, especially after a radical dissection?
Excision of the sternocleidomastoid muscle and the spinal accessory nerve inevitably leads to shoulder drop and reduced range of motion. Once the surgical incision is healed and the drains are removed, the nurse must initiate and reinforce specific prescribed rehabilitation exercises, gentle head turning, shoulder rotation, arm swings, to promote maximal function and prevent permanent immobility. This physical therapy is non-negotiable for long-term quality of life.
Let's detail the management of those severe collaborative problems, starting with hemorrhage.
The monitoring is intense. Vital signs every 1 to 2 hours or every 15 minutes if there's instability noted. We strictly instruct the patient to avoid the Valsalva maneuver straining, coughing hard, as it increases venous pressure on the wound. If a carotid artery rupture is suspected, which is a catastrophic event, the nurse must immediately apply continuous firm pressure to the bleeding site or the vessel, elevate the head of the bed to 30 degrees, and notify the surgeon immediately. We're talking minutes, not hours.
Next, the leak. What is it and how is it managed?
This is the leakage of milky lymphatic fluid from the thoracic duct. It's often noticed postoperatively, especially after the patient begins oral intake. Conservative management aims to reduce lymph flow, so we initiate enteral feeding or a strict low-fat diet, specifically using medium-chain fatty acids like from coconut oil, which are absorbed directly into the portal circulation, bypassing the lymphatic system and reducing chyle production.
And pharmacologically.
The synthetic somatostatin analog, octreotide, is frequently used to reduce the volume of lymph flow.
Finally, nerve injury. What are the specific nursing assessments related to function?
We look for specific deficits. Lower facial paralysis suggests a facial nerve injury. Difficulty with tongue movement suggests an injury to the hypoglossal nerve, which requires speech therapy for swallowing and speaking. But the most common chronic problem is the shoulder dysfunction caused by the spinal accessory nerve injury, which requires extensive long-term physical therapy involvement.
We've established that many of these patients require feeding tubes. That transitions us perfectly to Section 7, delivering nutrition enterally.
Right. And enteral nutrition is the preferred method when oral intake is insufficient, but the GI tract is functional. It's safer, it's lower cost, and it's physiologically better tolerated than parenteral nutrition, which bypasses the gut entirely.
When do we choose a nasoduodenal tube versus a long-term gastrostomy?
Nasoduodenal or nasojejunal tubes are used short-term if the stomach needs to be bypassed, maybe due to gastric motility issues, or if the patient is at an extremely high risk for aspiration. But for feedings that are expected to last longer than 4 to 6 weeks, a surgically placed gastrostomy or jejunostomy tube is always preferred for comfort and infection control.
A vital concept in enteral feeding is osmolality, and its direct link to dumping syndrome. How does that rapid shift occur?
The key is that high osmolality formulas, when they're introduced too quickly into the small intestine, they pull a rapid fluid shift. The small intestine, which normally has a fluid osmolality around 300 millosm/kg, suddenly receives this hyperosmolar fluid, causing massive amounts of water to be drawn from the vascular space right into the intestinal lumen.
And that fluid shift is what triggers the classic symptoms.
Exactly. The symptoms of dumping syndrome here are the same: fullness, severe cramping, diaphoresis, dizziness, and that osmotic diarrhea, all of which can lead to rapid dehydration and hypotension.
So prevention is entirely about slowing down the transit and minimizing that osmotic pull. What are the key strategies?
We have to strictly adhere to a few techniques. Slow the infusion route down, administer the formula at room temperature because extremes stimulate peristalsis, use a continuous drip administration rather than a bolus for initial tolerance, maintain the patient in a semi-Fowler position for at least 1 hour after feeding, and use minimal water flushes. If we introduce too much water, we just exacerbate the osmotic effect.
Let's quickly review the formula types because they're really customized for patient need.
So polymeric formulas are the most common. They require normal digestive capability. Specialty formulas are disease-specific for patients with renal failure, diabetes, or severe burns. Chemically defined or pre-digested formulas contain nutrients that are already broken down, so they're easier to absorb for patients with compromised GI function. And modular formulas are single nutrient supplements, like protein powders, used to boost a standard diet.
And the administration methods vary widely, which impacts nursing workload and patient quality of life.
Right. Bolus feedings use a large syringe to deliver formula over 15 to 60 minutes, which is practical for mobile or home patients. Intermittent gravity drip takes 30 minutes or more. Continuous feeding is a slow, steady infusion over a long period. It requires a pump and is mandatory for critically ill patients or those at high aspiration risk. And cyclic feeding is often done overnight, over 8 to 18 hours, which allows the patient to be tube-free and mobile during the day.
The nursing assessment for a patient receiving tube feedings is comprehensive. What are the key safety checks?
We have to rigorously confirm tube placement, often with an X-ray initially, or checking pH and length before every intermittent feeding or shift change. The patient's head of bed must be elevated greater than 30 degrees at all times. We monitor closely for signs of intolerance, abdominal fullness, bloating, nausea, vomiting, and diarrhea. We also watch for systemic signs of dehydration or infection, and we make sure that open feeding systems have their containers and tubing changed every 24 hours.
There are some critical modern updates, especially concerning severe COVID-19 patients in the ICU.
Absolutely. Current guidelines mandate initiating enteral nutrition within 36 hours of ICU admission for severe COVID-19 patients, recognizing their high metabolic demand. Large bore NG tubes are preferred because they have a lower risk of clogging. Safety is crucial during insertion. Because it's an aerosol-generating procedure, the nurse must use full appropriate PPE, and the patient's mouth and nose should be covered with a mask if tolerated during insertion.
And what about managing feedings when the patient is in the prone position?
Prone positioning increases aspiration risk. To counteract this, when prone, the patient should be placed in reverse Trendelenburg, which means their head should be elevated 10 to 25 degrees. Some experts also advocate holding the feeding for about 1 hour prior to placing the patient in the prone position.
Okay, let's tackle a major practice shift: gastric residual volumes, or GRVs. I know many nurses were trained to check residuals every 4 hours and hold feedings if they were over 150 millimella. What has changed?
The paradigm has fundamentally shifted based on evidence. Major critical care guidelines from SCCM and ASPIN no longer advocate for routine GRV assessment. Clinical studies demonstrated that checking GRVs between 250 and 500 millimelo did not increase the incidence of aspiration or pneumonia. It often just led to unnecessary interruptions in nutrition delivery.
So what is current practice?
Well, if a facility still mandates checking, the feeding should only be held for 2 hours if the GRV is greater than 500 millilart. However, the trend is toward moving away from routine checks entirely and focusing instead on clinical signs of intolerance like vomiting, bloating, and abdominal discomfort.
While residuals are debated, tube patency is not. What's the strict flushing protocol?
Patency is absolutely essential for safe medication delivery and function. The protocol is strict. Flush with a minimum of 30 milliliters of water before and after every intermittent feeding, before and after every medication, after checking residuals or pH, and a minimum of every 4 hours during a continuous feeding. And a critical safety note. For any immunocompromised patients, sterile water should be used as best practice for flushing.
Let's move to the long-term access devices, gastrostomy and jejunostomy.
The gastrostomy, a PEG or rig tube, is preferred for any feeding expected to last longer than 4 to 6 weeks, and for comatose patients because the intact gastroesophageal sphincter lowers aspiration risk compared to nasal tubes. The insertion is typically done endoscopically, and it's secured internally by a bolster or bumper and externally by a retention disc.
How long does the stomal tract take to be safe for manipulation?
The tract takes about 30 to 90 days to fully mature. Before that 30-day mark, if the tube dislodges, it's a medical emergency because the tract can close very quickly. We also utilize low-profile devices like the MI key, which sit flush with the skin, are concealable, and improve patient mobility and comfort.
And the jejunostomy tube. What is the critical difference in care compared to a gastrostomy?
The jejunostomy is used when the gastric route is compromised or the aspiration risk is just excessively high. The critical nursing note here is that jejunostomy tubes should never be rotated because of the risk of disrupting the internal fixation sutures or mechanisms that secure it in the small intestine.
In the nursing process for these access devices, let's focus on infection and skincare.
For the first week, aseptic wound care is crucial. After that, standard soap and water cleaning twice daily is usually sufficient. We have to diligently assess the site daily for drainage, irritation, and the common complication of a candida infection, which often occurs under the external bolster. We use zinc oxide or other skin protectants for leakage management.
What intervention prevents buried bumper syndrome?
Buried bumper syndrome occurs when that internal bolster migrates into the abdominal wall. To prevent this, the nurse has to rotate the gastrostomy tube daily, but again, not the jejunostomy, and gently move it inward and outward about 2 to 10 centimeters weekly, starting after the first week of healing, to prevent tissue adherence.
And if a tube clogs?
Prevention through adequate flushing is key. If a clog does occur, the first intervention is to use warm water and a 30 to 60 milliliter syringe, utilizing a gentle push-pull pressure. If water fails, a commercial enzyme-containing kit is the next step.
We've covered the delivery system. Let's shift to Section 8. Disorders of the esophagus. This is a critical area for nursing assessment. We'll start with achalasia.
Achalasia is a severe motility disorder defined by 2 key elements: absent peristalsis and the failure of the lower esophageal sphincter, or LES, to relax. Because the LES remains tightly closed, the esophagus above that point dilates significantly, creating that classic bird's beak deformity you see on an X-ray.
What are the clinical signs, and why is it so often misdiagnosed?
The primary symptom is worsening dysphagia, initially with solids but eventually liquids too. Patients commonly experience regurgitation of undigested food and non-cardiac chest pain. They also often report pyrosis or heartburn, which leads them to be inappropriately treated for GERD. The definitive diagnosis requires high-resolution manometry to measure the pressures and lack of coordination.
Management options are pretty varied.
They are. We counsel patients to eat slowly and drink fluids with meals. Treatment ranges from a temporary botulinum toxin injection to paralyze the sphincter muscle to pneumatic dilation, which uses a balloon to stretch the LES. Dilation has a high success rate, but it does carry a small but serious risk of perforation. The surgical option is the esophagomyotomy, or Heller myotomy, where the muscle fibers are cut. This is often paired with a partial fundoplication to prevent subsequent reflux.
Next, esophageal spasm, which has specific classifications.
Yes. We differentiate between diffuse esophageal spasm, which is uncoordinated, non-propulsive contractions, jackhammer esophagus, which is hypercontractile, extremely high amplitude contractions, and type 3 achalasia, which is an LES obstruction with strong spasms. The symptoms overlap heavily with achalasia, dysphagia, and chest pain. Management focuses on smooth muscle relaxants like calcium channel blockers and nitrates, alongside small, frequent soft feedings.
Moving to the anatomical issue, the hiatal hernia.
This is an enlargement of the diaphragmatic opening, which allows a portion of the stomach to move up into the chest cavity. We distinguish between the sliding hernia, type 1, where the stomach slides in and out, that's the most common, about 90%, and the periesophageal hernia, which are types 2 through 4.
Why is the periesophageal hernia more concerning?
Because the stomach pushes up beside the esophagus and remains fixed, it carries a much higher risk of acute complications like hemorrhage, obstruction, or critically strangulation, which is a surgical emergency.
And the management is focused on preventing the reflux symptoms associated with the hernia.
Lifestyle management is paramount. Frequent small feedings, avoiding reclining for at least 1 hour after eating, and elevating the head of the bed by 4 to 8 inches on blocks. Surgical repair, usually a laparoscopic fundoplication, is typically only performed to resolve intractable chronic GERD symptoms.
Esophageal diverticulum, the outpouching of mucosa.
The most common is the Zenker diverticulum, or ZD, located in the pharyngoesophageal area. It acts like a trap, filling with food and causing profound symptoms. Dysphagia, regurgitation of undigested foods, sometimes hours after eating, neck fullness, gurgling sounds, and severe halitosis from food decomposition.
There's a vital safety alert for the nurse assessing a patient with ZD.
Absolutely critical. Due to the high risk of perforation, we must avoid esophagoscopy and, more importantly, never attempt blind insertion of an NG tube. If you suspect a ZD, an NG tube can easily enter the pouch and perforate the esophagus, leading to immediate mediastinitis. Management involves endoscopic septotomy or surgical excision.
Esophageal perforation is listed as a major surgical emergency.
It is catastrophic. The causes include medical procedures like endoscopy, severe trauma, or the spontaneous rupture from forceful vomiting, which is known as Boerhaave syndrome. The clinical triad is dramatic. Excruciating retrosternal pain, dysphagia, and fever, often progressing rapidly to severe hypotension and signs of sepsis.
What are the immediate nursing and medical priorities?
Immediate NPO status, aggressive IV fluid resuscitation to combat shock, and broad-spectrum antibiotics to prevent mediastinal sepsis. Surgical repair is almost always required. Postoperatively, the patient is kept NPO for 7 full days, requiring enteral or parenteral nutrition, and a repeat esophagram on day 7 is mandatory to confirm there's no leak before oral intake is even considered.
For ingested foreign bodies, the initial focus is the airway.
Airway focus assessment is always first. We might use glucagon, 1 milligram 3/5, to cause muscle relaxation in the esophageal wall, which sometimes allows it to pass. Endoscopic removal using forceps or snares is standard. But we have another safety rule. Ingested drug packets are never removed endoscopically because of the catastrophic risk of rupture and overdose.
Chemical burns, often from swallowing strong alkaline agents.
The acute phase requires intense management of shock, pain, and respiratory distress. The most critical nursing intervention here is protection from secondary injury. We must avoid inducing vomiting and gastric lavage because that forces the caustic substance back through the esophagus, causing secondary deeper burns. Long-term, these patients require complex nutritional support and dilation for stricture formation.
Finally, the highly prevalent gastroesophageal reflux disease, or GERD.
GERD is that chronic, symptomatic backflow of gastric contents. The causes are multifactorial: an incompetent LES, a hiatal hernia, tobacco and alcohol use, and even H. pylori infection. The primary symptoms are pyrosis and regurgitation.
What's the definitive diagnostic tool?
Ambulatory pH monitoring is the gold standard. It confirms the frequency and severity of reflux episodes. Endoscopy is also used to evaluate the extent of the mucosal damage.
Let's discuss the pharmacologic management and specifically the risks associated with the main drug classes.
For antacids and H2 receptor antagonists like famotidine, while they reduce acid, prolonged use can alter the gut flora, which increases the risk of C. difficile infection.
And the first-line treatment is the PPIs. What are the major long-term side effects that nurses need to educate patients about?
Proton pump inhibitors, omeprazole, pantoprazole, are highly effective acid suppressors, but they carry significant long-term risks. There's an increased C. difficile infection risk, an increased risk of hip fractures, and interference with the absorption of essential micronutrients like vitamin B12, iron, and magnesium. So they should be used at the lowest effective dose for the shortest necessary duration. Prokinetic agents like metoclopramide accelerate gastric emptying, but are used short-term due to the risk of irreversible tardive dyskinesia.
And GERD is dangerous because it can progress to Barrett Esophagus, or BE.
BE is the changing of the esophageal lining from squamous cells to columnar epithelium. This condition is the only known precursor to esophageal adenocarcinoma, or EAC. The risk factors are additive: GERD severity, smoking, obesity, and family history. Management requires intensive surveillance biopsies, high-dose PPIs, and endoscopic ablation techniques using heat or cold energy if dysplasia is detected to try and destroy the precancerous cells.
This leads us to our final clinical topic, Section 9, Cancer of the Esophagus.
Esophageal cancer is aggressive, though survival is slowly improving. Adenocarcinoma is the rapidly rising type, typically found in the distal esophagus, and it's often related to BN-GERD. Squamous cell carcinoma is linked to chronic irritation from hot liquids, alcohol, and poor oral hygiene.
Dysphagia is again the primary symptom, but patients often delay seeking care.
They do. They typically delay for 12 to 18 months because they just adjust their diet to softer foods. By the time they seek help, the lesion is often large. The progression is classic. Dysphagia first with solids, then rapidly progressing to liquids. Later symptoms include the sensation of a mass, painful swallowing, hiccups, and hemorrhage.
Management often involves the highly invasive esophagectomy.
Yes. The goal is to remove the tumor and the surrounding lymph nodes. Techniques vary, including the transchiatal esophagectomy, where the remaining esophagus is anastomosed directly to the stomach, which has been mobilized up into the chest. If the stomach can't be used, a colon graft transfer may be required.
The postoperative nursing care for an esophagectomy contains a critical safety warning concerning the NG tube.
This is arguably the most vital postoperative safety alert in this entire chapter. The NG tube is placed during surgery and it's secured. Under no circumstances should the nurse manipulate, reposition, or irrigate the NG tube if it is dislodged or malfunctioning. The risk of damaging the surgical anastomosis site and causing a fatal leak is just too high. The tube is only removed after a barium swallow, usually around day 5, confirms the anastomosis is healed.
Besides the NG tube, what are the major complications?
Aspiration pneumonia is a high risk, requiring vigorous pulmonary care incentive spirometry, early ambulation, but note that chest physiotherapy is avoided near the incision. Atrial fibrillation is common due to vagus nerve irritation, and the risk of an anastomotic leak, which is managed with immediate NPO status, drainage, and antibiotics, is constant.
And what about the high incidence of vagotomy syndrome post-esophagectomy?
This is the surgical version of dumping syndrome, and it affects up to 39% of patients. Because the vagus nerve is often interrupted, gastric emptying control is lost. The rapid dumping triggers severe abdominal cramping, explosive liquid bowel movements, sweating, and a rapid heart rate, typically occurring 20 minutes to 2 hours after eating. Management requires adherence to a soft diet, small frequent meals, separating liquids and solids, and remaining upright for a full 2 hours after a meal.
Finally, let's quickly synthesize the nursing process for non-cancerous esophageal disorders.
Our comprehensive assessment requires a detailed history. When do the symptoms occur? Does position affect them? What foods trigger them? Nurturing interventions really focus on 3 goals: promoting nutritional intake by slow eating small meals, avoiding irritants, decreasing aspiration risk with a strict semi-Fowler position and teaching how to use oral suction, and relieving pain by maintaining an upright position for 1 to 4 hours after meals, HOB elevation, and adherence to prescribed acid suppressors.
We have dissected the entire range of disorders across the upper GI tract, from oral cavity prevention all the way to complex post-thoracic surgery care. Let's finish with our essential takeaways for the nursing student.
We've covered a vast amount of ground, but the core nursing priorities in this field, they really synthesize into 3 major life-sustaining responsibilities.
Priority 1, maintaining a patent airway and aggressively preventing aspiration.
This is the highest priority in post-op neck dissection, in managing foreign bodies or perforation, and in safely administering enteral nutrition. If you hear stridor, you act immediately.
Priority 2, ensuring adequate nutritional intake via the appropriate route.
This means selecting the correct route: oral, soft, tube, meticulously managing tube feeding administration, ensuring patency with proper flushing, monitoring for intolerance, and proactively managing complications like osmotic or post-vagotomy dumping syndrome.
And priority 3, providing comprehensive psychosocial support and education.
The conditions here involve chronic pain, communication deficits, and significant body image changes. The nurse has to provide empathy, individualized education on complex self-care drains, tracts, feeding tubes, and ensure robust referral to rehabilitation and psychosocial services.
It all comes back to that initial simple assessment. Our final provocative thought focuses on that vigilance.
Remember our discussion of oral lesions, particularly erythroplakia. That seemingly small, red, painless patch carries a tremendously high risk of becoming cancer. The nurse who is performing a routine head-to-toe assessment, who identifies a sore that won't heal or a suspicious red patch, performs a critical function. That simple routine inspection and timely referral can lead to a diagnosis when the cancer is highly curable, emphasizing that the most basic nursing skill can be the most powerful tool in prevention and early detection.
A perfect reminder of the power of clinical observation. Thank you for diving deep with us today.
Thank you for joining us on this vital deep dive into patient management.